Good afternoon, everyone. Thank you for being here. My name is Sydney Carter. I'm the Program and Policy Coordinator at the Network of Behavioral Health Providers. And today is our February CEU training on screening, brief intervention, and referral to treatment, SBIRT, helping clients address substance misuse. And NBHP is proud to be a United Way funded partner. And I'm delighted to introduce our speaker today, Ms. Sandra Gonzalez, and she is going to be leading us today. And I would just ask if y'all wouldn't mind muting yourselves as you come in, and I'll be monitoring the chat. If you have any questions, please go ahead and put that in the chat. And then as a reminder, 2 credits of CEUs will be available to licensed social workers, LMFTs, and LPCs, but you have to join the presentation by 2:15 p.m. and stay for the whole presentation. And you have to complete the CEU survey by 12 p.m. tomorrow. And the link will be placed in the chat at the end of the presentation. So I appreciate y'all's attentiveness. And again, I'll be monitoring the chat for questions, but I will go ahead and pass it over to Sandra. Thank you. To Sandra.
Thank you so much, Sydney. And hello, everyone out there. Appreciate you joining me this afternoon. My name is Sandra Gonzalez. I'm an assistant professor in the Department of Family and Community Medicine at Baylor College of Medicine. I am also the project director for Aware Houston, and Aware Houston is a SAMHSA-funded mental health awareness training grant. So we've had this grant since April of 2020. You can imagine how interesting it was to launch a training grant that was supposed to be done in person in April of 2020. So we have definitely pivoted and adjusted. And now the vast majority of our trainings are via Zoom. So we're going to go ahead and get started. We've got a lot of material to cover. I'm hoping that I can stay on track so that we can finish with a little bit of time to spare for questions. Okay, so as Sydney mentioned, we're going to be talking about SBIRT, and SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And it is an evidence-based public health approach that's used to identify patients or clients. And by the way, I'm going to use those terms interchangeably. I'm someone who's been in the healthcare field since 1994. So patients is something that I tend to use because of the setting I work in, but I'll do my best to use clients as well. And so it's used to identify patients or clients who use alcohol or drugs at excessive levels. I found a great quote sort of that gets to the essence of how impactful it can be. And that quote is—
Sorry, I double booked myself today.
I think we have someone that's not muted.
I think that was just a unmute by accident. So
Okay. So SBIRT has been referred to as one of the most successful examples of translational research in the history of addiction science. So hopefully what we're going to talk about today is going to be something that you, if you're not already doing some degree of it, that you'll be able to implement into your practice. We're going to be covering all 3 elements of the approach, and we're going to start with screening. You are going to notice that some of the language may seem more geared toward the healthcare setting. However, this approach is translatable to many practice settings, including traditional behavioral health. And I've been training on SBIRT for quite a long time. Before I had the mental health awareness training grant, I was also on an SBIRT specific grant that provided this training to healthcare professionals and mental health professionals. Okay, so the goal of this session is to provide all of you professionals with the information, tools, skills, and resources to successfully screen patients. By the end of the session, I hope that you will understand the rationale for universal screening, be able to identify potential health impacts of substance misuse and substance use disorders, that you're able to identify substance use risk limits, and that you're able to identify how screening is conducted in a practice setting, including the use of pre-screening and screening instruments. So why universal screening, right? This is the most important question related to screening. And when we talk about this, it's inevitable that folks will say, well, I'm not sure if my patients will like it. I don't know if they'll be comfortable. I don't know if I'll be comfortable talking about some of these topics. On the medical side, I get a lot of, it's going to take too long. What if I do find a problem? What am I going to do then? And so we're going to talk about all of those points throughout this afternoon. But at the end of the day, the most integral part of the S in SBIRT is that universal screening. So drinking and drug use are far more common than we think. And drinking and drug use increase the risk of health problems and create safety risks, as well as a host of other social and legal consequences. So when we integrate screening as a universal process, it normalizes the clinician and client conversations regarding substances because we screen everyone, right? We're not picking certain people in our practice to screen, we're just screening everyone. Another reason is because drinking and drug use often go undetected. There are some unconscious biases that can present themselves, and that can affect the way that clinicians address problems like substance use. Sometimes people may look a certain way. Maybe some people look like us, and we unconsciously don't think that they might be at risk. So if we don't ask, we don't know. And it has to be more than this yes or no question, right? Do you drink? What sort of response do you imagine you're going to get to a question like that? And next, studies over and over have demonstrated that people are far more open to change than we might expect, particularly persons who maybe are drinking at excessive levels and maybe haven't quite progressed to the level of meeting criteria for a substance use disorder. Maybe they assumed that they weren't at risk, right? So those folks, once you begin to talk to them, once you begin to use some of these skills, you're going to introduce that idea that maybe some of the behavior related to alcohol use or drug use could be affecting them in other ways. So universal screening detects health problems related to at-risk alcohol use and substances at an early stage. This is particularly important because you want to capture it before it becomes a more serious disease or begins to have more serious health consequences. Being able to detect alcohol and substance use patterns can help to prevent future injury or illness. And screening serves to intervene and educate about at-risk or hazardous alcohol or other substance use, the risk and the consequences. So, screening is a really effective first step toward intervention. And all of you are typically the first point of contact, at least in the healthcare sphere, regardless of what setting you're in. And if you are able to identify problems with alcohol or drug use and intervene earlier, we know that that's going to produce better outcomes. In the medical sphere, and I'm not sure if there are many of you who are in healthcare settings, but for those individuals, a lot of times these aren't the things that they come to their primary care provider to talk about. What they come to talk about is some other physical problem. And it might be in that encounter that it's discovered that they may be struggling with a substance use issue. So here are just some statistics on the prevalence of substance use. So for tobacco, we know that that's gone down pretty significantly over time as a result of the research and everything that we know about the hazards of tobacco use. Obviously, now we also have concerns around vaping. So for tobacco use in 2019, it was about 17.4% of the female population and 28.6% of the male population. For alcohol, and this is past month use, so current drinkers, about a little over half of females and 59.1% of males. And then illicit drugs, and this does not include marijuana. This is illicit drugs aside from marijuana. Females 7.4% and males 10.1%. So you're going to see this pyramid several times during the presentation, and it used to be called the drinker's pyramid. And this pyramid ties very nicely to the two instruments that I'm going to be talking about the most today, the audit and the DAST. So we know that substance use exists on a continuum of behavior, right? So if we're screening all clients 12 and older, that's going to help us to understand where they are on that continuum. So depending on where they fall, we can either provide reinforcement that they are being abstinent or engaging in non-excessive use. We can intervene early, as we talked about just a couple of minutes ago. And we can also provide patients with substance use disorder treatment, if that's something that we do, or refer them out to treatment. It's important to note there at the bottom of the pyramid, that green section, most patients are going to screen as abstinent to all substances or non-excessive drinking. As a note, there is no non-excessive limit when we talk about nicotine or other substances besides alcohol. Right. So when I talk about non-excessive, I'm specifically talking about alcohol. The majority of the patients that are screening positive in healthcare settings, that's about 25% of adult patients are going to be at that excessive use level. So the little blue there right above. Those are the people who don't yet have a diagnosable substance use disorder. And those are the people for whom SBIRT works the best, right? And there's only going to be a fraction of individuals that you screen that will have a diagnosable substance use disorder. And that's about anywhere from 5 to 10%, or up there, in the mild to moderate substance use disorder to severe substance use disorder categories. Okay, so there are many health impacts when we talk about the use of alcohol drugs. They're well documented for individuals who are drinking at the level to meet DSM-5 criteria for moderate or severe alcohol use disorder. We see that nearly all systems of the body can be adversely affected. So we see here the liver, the stomach, the pancreas. We also know that it affects cardiovascular health. So things like hypertension and heart disease may be worsened depending on the person's substance use. And then, of course, there are some short-term effects as well because of the risk that people might put themselves in when they're under the influence. Okay. So this slide here just shows a workflow. Workflows are really important because they get at that major question, which is, how are we going to incorporate this into everything else that we are already required to do? So I tell folks the SBIRT intervention works best when you embed your screening process into your normal workflow. So basically you're making it invisible, right? Just a part of what you normally do. In healthcare settings, for example, it's going to be like taking blood pressure or height and weight, right? And in most practices, we encourage folks, and they do, to use a team approach to SBIRT implementation. So we see here, this is just a particular clinic where the patient arrives at the registration desk. They receive a health and wellness form or intake form. We've all completed them at some point. And embedded within that health and wellness screen are pre-screening questions. So there can also be questions about diet, exercise, tobacco use, anything that you deem important in terms of your wellness screening. And this approach works best because it normalizes screening for substance misuse or substance use disorders within the context of overall health and wellness. So here I'll briefly go through it. When the medical assistant or whoever else might be involved in the team takes the patient or client into the exam room, then they will complete the audit, which is the alcohol use disorders identification test, and the DAST, which is a 10-item question for drug use. And this can be done by interview, paper and pencil. You can use tablets, which is pretty popular now. And if you don't have a positive screen, and remember that's going to be the vast majority of your folks, then no further action is required. If you do have a person who screens positive, then depending on the level will determine whether you're going to provide a brief intervention, or if the level of severity is higher, then we're going to be talking about whether that patient needs to be referred out to specialty treatment. The screening strategies are brief, but they're very valid. The questions recommended for use are the NIAAA single question screener or the Audit C. And the Audit C is simply the first 3 questions of the audit. And then there's also an accompanying NIDA single question drug screen. And again, in traditional medical settings or primary care, we're talking about anywhere from about 20 to 25% of individuals who screen positive. For all of you, you're in behavioral health settings. I presume a large number of you are. Those settings are naturally going to have higher rates of positive screens. So the pre-screening is quick, it's effective, and it's where we make that first decision. So in the pre-screening for alcohol, we ask, do you sometimes drink beer, wine, or other alcoholic beverages? If the answer is no, then we don't need to ask any further questions. However, if the answer is yes, then we want to use the NIAAA single question screening, single question screening tool, which is how many times in the past year have you had 5 or more drinks in a single setting, if male, or 4 or more drinks in a single setting, if female. If the answer to that question is 1 or more, then we want to make sure to complete the full alcohol screening using the audit. We're going to talk about that in just a couple of minutes. Alternatively, if you don't want to use the single question, which, it really depends on how much time you have with the patient or client, then you could use the audit C, which is 3 questions. And again, these are for pre-screening only. You'll have to follow it up with the full audit or one of the other validated instruments that's out there. I'm happy to provide those resources to y'all after the presentation. Unfortunately, we can't go through every one of those in 2 hours. Okay, so another question that's important is to determine their average drinking limits in both a day and a week. So the weekly drinking limits were established as a result of an NIAAA study that assessed long-term health consequences of alcohol use. So in other words, people who consumed at a higher rate than these drinking limits were at long-term risk for health consequences. So we want to get an understanding, on average, how many days a week do you have an alcoholic drink? And then on a typical drinking day, how many drinks do you have? Okay. So the limits are, for men, no more than 2 drinks per day and no more than 14 drinks per week. And then for women or anyone over the age of 65, it's 1 drink per day and no more than 7 drinks per week. I want to make sure to say that in order for the person to be healthiest, we want to make sure that they are staying within both of those limits. So I just met with a patient this morning and we were talking about this topic. And I said, you can't save up your drinks, right? So you can't not drink for 5 days and then on the 6th day say, okay, well, I'm going to have 7 drinks today, right? We want to keep that number 3 or below for women on a daily basis and less than 7 on a weekly basis. The other thing that we notice, aside from maybe the person exceeding daily or weekly limits, is binge drinking. So binge drinking can be both drinking in excess beyond the limits that we just discussed or having binge drinking episodes. And just to kind of, I get a lot of questions around, well, who set up these guidelines and patients don't think this way, et cetera. There's actually considerable research out there that was generated from foundational NIAAA studies. And they confirm that exceeding these limits that we're talking about today can significantly increase the risk for alcohol-related problems. And those are readily available through NIAAA, through NIDA, and through HHS at the federal level. So studies also demonstrate that 5+ or 4+ limit accurately reflect the amount of alcohol consumed at which we start to see psychomotor and cognitive impairment. And that's in both men and women. And then we see through some of the epidemiologic studies that when you go beyond these limits, there are pretty rapid increases in things like unintentional injuries, deaths resulting from external causes, being a target of aggression or taking part in an aggression-related event, alcohol use disorders, and then unfavorable medical, work-related, legal, and social consequences. And it's a dose response effect, right? So the greater the increase in exceeding those limits, the higher the likelihood that these problems may develop. So this is one of my favorite slides. I have several. This is the one I chose for today because of this presentation. The most important thing for that we can do for our patients is help them understand exactly what is a drink, right? So what do we mean by a single drink? I think the fellas here who are enjoying this beverage are probably having more than one standard drink. One standard drink is defined as 5 ounces of wine, 12 ounces of beer, or 1.5 ounces of spirits. All of those have the equivalent amount of alcohol by volume, and that is 14 grams. So again, this is just giving you a little bit more information about the standard drink. So if your patient or client is saying, oh, I'm drinking a bottle of wine a night, that's about 5 standard drinks. Okay, so right there, you already have that person exceeding the daily limit and potentially exceeding the weekly limit if they're doing this often. And a note about beer also, when we talk about this 12-ounce glass of beer, we're talking about beer that has 4 to 5% alcohol by volume. These days, you have a lot of the craft beers that have considerably more than that. They may have 25 to 50% more than that. So that needs to be taken into account as well. Not all beers are created equal. And this is just another graphic that demonstrates the standard drink. All of these are the same. And in particular, when we talk about the spirits, that 1.5 ounce being a standard drink, if you have a client who's saying, you know, I really enjoy those Long Island iced teas. Okay. Once again, you know, how is that drink made? How many shots go into that? And that's going to give you an idea of the number of standard drinks. It's not just one. There have been quite a few patients who have told me, you know, I only have 1 or 2 drinks per night, and that sounds fine until you start to ask first what sort of containers they're using to drink from, and secondly, what kind of drinks exactly they're using. All right, so we're going to spend most of the time talking about the audit, or the alcohol use disorders identification test. As I said a few minutes ago, there are many validated screening instruments that you can use depending on your preference, your population, and your practice setting. So the audit is in the public domain. It was created by the World Health Organization. You can download a copy from the WHO website. It's simple and straightforward. And as I said a few minutes ago, it can be administered in many ways. It can be self-scored by the patient, can be administered by someone in the office, and it can also be embedded into the tablet or the electronic health record. It has many strengths in terms of prevention and early intervention. It's validated for use in many settings. It's been translated into numerous languages, so that may be a benefit to those of us who are working with diverse populations. And it gradates risk from low level to high level. And high level is presumed to be consistent with something like a moderate or severe alcohol use disorder. The limitation here, and the reason why we have to use the audit and the DAST, is because the audit only screens for alcohol. There is a US version of the audit that's available. Some of you may be familiar with it. It is, interestingly enough, called the US audit. And it makes an adjustment to the first 3 questions of the regular audit, and it adjusts for the standard US drink size. So on the international version, it's assuming 10 grams versus 14 grams. So you'll notice that on the audit, the 3rd question says, how often do you have 6 or more drinks? That's because that question is based on 10 grams. Okay. So here's a screenshot of the instrument. Again, here you'll notice in question 3, how often do you have 6 or more drinks on one occasion? Never, less than monthly, monthly, weekly, daily, or almost daily. And remember that if you are administering this yourself or having someone in your office do it, that you will need to read every question as is and read every response as is every time. We want to make sure that we keep the instrument valid. Now, the domains, I think, are really interesting, and they do give us a lot of information about the frequency of the drinking, how often they're drinking, how often they're drinking at levels that are considered heavy. It also gives us an idea on what we used to call dependence symptoms. And you may see some differences in some of the slides and what I'm saying. So I want to provide a little bit of clarification there. So since we have had the DSM-5, we no longer use some of the old language, and alcohol dependent is actually one of those terms that we don't use anymore. So we're really referring to folks with a moderate or severe alcohol use disorder. And so questions 4, 5, and 6 help us understand better their control over drinking, whether maybe they're having a drink first thing in the morning. And then those last few questions ask about, does the person feel guilty after drinking? Have they experienced blackouts? Have they had injuries that were related to their alcohol use? And have they had someone in their life approach them and express concern about their drinking? All right, so again, let's go back to the drinkers pyramid. The scoring of the audit really matches that. So again, about 40% of the people are going to score at low risk or no use of alcohol at all. Okay. And we consider those folks in the abstinence category, and that's a score anywhere from 0 to 7. And then we have about 35% of people who demonstrate some level of risk with their use, and that scores between 8 and 15. And then we have about 20% of folks who are using excessively and may meet criteria for a mild substance use disorder. And those are scores 16 to 19. And then lastly, again, for moderate or severe, that's really only about 5% of the population that you will either need to provide substance use disorder treatment, or you're going to refer them out for treatment. Okay, so now let's talk about pre-screening for drugs. So how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Okay. For instance, because it made you feel high or because of some experience that you had. If the response is none, haven't used in the past year, then the screening is complete. If the response is vague, contains kind of suspicious clues, then you may want to inquire further. In terms of the pre-screening for drugs, obviously the sensitivity is going to be 100%, right? People all have or have not used in the past year. And then specificity, we don't know exactly what they're doing based on an answer of yes or no. So the specificity is going to be a little bit lower. Okay. Now, it's important because we've just talked about alcohol that we distinguish with alcohol. There are levels of risk. On the drug screen, any positive result on the drug pre-screen is going to put that that client in the at-risk category. So the follow-up questions that we use are there to assess impact and whether their use is serious enough to maybe warrant further evaluation for a substance use disorder diagnosis. But if the response is never, then the screening for drugs is complete. Sometimes there can be overt clues that indicate that a person is using, how they appear. They might appear high, they might appear intoxicated. And if that person responds positively, no matter how many times, whether once or multiple times, that person is considered at risk, and you want to conduct further assessment, further screening. Prescription drug use, as you all know, is a big problem. We saw increases in opioid use during the pandemic. We also saw an increase in overdose deaths. So although people may take different kinds of medications that aren't prescribed to them, we are primarily concerned with things like the opioids, things like oxycodone, hydrocodone, fentanyl, and methadone, the benzodiazepines or the anxiety reducing medications, things like clonazepam, alprazolam, diazepam. Stimulants, so this is where we might see folks screen positive when they are using a prescription medication that was given to them, by a physician. Maybe they have a diagnosis of attention deficit hyperactivity disorder, but they are using more than what is prescribed to them. So that would be misuse. And then sleep aids, things like Zolpidem, which is brand name Ambien. And then it could be other medications as well. So for example, Caresperdal is muscle relaxant medication. So there are several prescription medications that can be misused. All right, so we are going to be using the DAST, which is the full screening tool for drugs, and it is a shortened version of the DAST 28, and it contains 10 items. It can be completed as a self-report or via interview, and the screening questions parallel another screening tool called the MAST, and that's the one that's specific for alcohol. The strengths of the DAST are that they're a sensitive screening tool for individuals who are engaged in at-risk drug use. And again, similar to the audit and the reason why we use two instruments, the weakness is that it does not include alcohol use. That's why a lot of times folks I've noticed really are just focusing on those single question alcohol screen and the single question drug screen. Just makes things easier. It's not as time consuming. And then you can certainly use the full audit or DAST to get more information. So here you see the full DAST 10 questionnaire. And again, these are available in the public domain. And the DAST was originally developed by the Addiction Research Foundation, which is now called the Center for Addiction and Mental Health Canada. And it yields a valid quantitative index of problems related to use. As I said, you can do it self-report, interview, electronically. If you see here, if the person scores 0, no problems reported. In terms of suggested action, you don't have to do anything, but I often like to give a reinforcement message for this as well. It sounds like you're really making good decisions about your health. And this is one of the ways in which you are taking care of yourself, right? If it ever becomes something that you're concerned about, you can come and talk with me. So we're leaving that door open, reducing the stigma. Scores of 1 to 2 are low level. You want to monitor and reassess at a later date. Scores of 3 to 5 are moderate level. You definitely want to investigate further. And then when you have scores of 6 to 8, this is the group of folks that may require that referral to treatment based on a more comprehensive assessment. All right, so we're back to that pyramid. So similar to the audit's results, the DAS reveals that about 40% of persons report no level of illicit substance use in the past year, or they're also not reporting the use of medications in ways that were not prescribed. About 35% are in the hazardous use category, score of 1 to 2. A score of 3 to 5 is indicative of excessive use and potentially mild substance use disorder, about 20%. And then that 5% there that's going to score above 6 and might be someone who is experiencing moderate or severe substance use disorder. So before we're going to move on to the BI, I wanted to make sure that we took away some really important points when it comes to screening. So first and foremost, we screen everyone. You want to screen for both alcohol and drug use, including their use of prescription drugs and their use of tobacco. You want to use a validated tool. There are many out there. What you don't want to do is ask questions like, you don't drink, do you? Okay. So that's not going to get us very helpful information. Pre-screening is really valuable because, as I said, sometimes it can seem really intimidating to do this particular prevention intervention. So if you can pre-screen, then you're going to rule out a lot of people who are not going to need additional, whether a brief intervention or setting them up for referral. It's important to explore all substances because many clients are going to be using more than one. So they may be using alcohol, they may also be using marijuana or some other illicit drug. And then you always want to follow up. Okay. So if a person is screening positive, you want to assess the details of their experience, right? What are the red flags? What's going on in their lives where they can see that maybe their use of these substances is causing them trouble? And we're going to talk briefly about motivational interviewing, but you want to use those motivational interviewing skills even in screening, because that's going to demonstrate a non-judgmental attitude. It's going to convey empathic, both verbal and nonverbal behaviors, and that's going to help to build rapport and set the person at ease. Nope. Okay. This is just a summary here. In particular, I like this part here that screening really is often the process that sets in motion a client beginning to reflect on their substance use behavior, maybe ask some questions around it and get clarification. So this is a really good opportunity for prevention of consequences that could affect health and mental health down the road if they're not appropriately addressed. Okay, I'm going to hold on the video until the end just to make sure we have time. I also think the video really just captures the entire presentation really well in terms of demonstration of all the skills. So we'll hopefully come back to that. If not, you'll have the link in the PowerPoint. So let's go ahead and move into a discussion on brief intervention, or sometimes it's referred to as the brief negotiated interview, or the BNI. Okay. And the objectives for this part of the presentation are to describe an evidence-based practice model of brief intervention, which is known as the brief negotiated interview, and then apply specific motivational interviewing skills to the BNI. This is just a reminder, right? What is the primary goal? And the primary goal of SBIRT is to identify and effectively intervene with those who are at moderate or high risk for psychosocial or healthcare problems related to their substance use. Again, substance use exists on a continuum, and SBIRT helps us to target those folks in particular with the BI who are, in the non-excessive use category, and sometimes the excessive use, even though at times that you can find a person who maybe doesn't respond as well to brief intervention, or they might say, I really want to go into treatment. But by and large, we're talking about people who don't meet criteria for a substance use disorder, but have maybe started to develop some misuse patterns. So brief intervention is a brief motivational and awareness raising intervention that's given to individuals who are misusing alcohol or drugs. And there are several models, including the BNI, which is what we're going to focus on today. And it was originally developed by Gail D'Onofrio and her colleagues. And it is a semi-structured interview process that's based on motivational interviewing. And it's a proven evidence-based practice. And I think positive for a lot of the audiences that I train is that it can be completed in 5 to 15 minutes. It's easy to learn, it's easy to teach, and it's something that has been taught to and used by many clinicians across the world. And it creates a step-by-step base for the brief intervention. All right, so we're going to go through each of these individually, but the steps in the BNI are to build rapport, raise the subject, explore the pros and cons of use, provide feedback, build readiness to change, and negotiate a plan for change. So first, building rapport, raising the subject. So remember that we've already done the screening, right? And there's been some sort of risk that's been identified. And we want to build rapport, right? We all know how to build rapport, but in this instance, we are building rapport to discuss a potentially sensitive topic. So this can start with a general conversation. It's always best to start in a low-key manner that doesn't evoke resistance. If you start to notice that the patient is feeling discomfort, or if they are feeling comfortable, you want to address that. If they seem comfortable talking with you, we want to show them respect, right? By asking permission if it's okay for us to continue to talk about their use of alcohol or their use of drugs, or both. So for example, we have a few scripts. One would be, would you mind taking a few minutes to talk with me about your alcohol and drug use? Another question that you can ask, what's a normal day look like for you? And where and how do drugs and alcohol fit in? A lot of times people will say, well, what if the patient just declines to talk to me about their use? That's actually a pretty big myth that we're aware of, because the reality is most people are going to agree, and there's actually going to be very few that refuse. If someone does refuse, that's okay. That's their choice. You still have your work to do. And, if you do have someone who says no, then there are ways that you can continue to leave that door open. That's really the point, not to convince them in that moment to make a change. So you might say something like, that's absolutely your choice. I can't make you discuss that with me. But part of my job is to ask everyone these questions. So I'm going to do that, but you don't have to answer. And if you change your mind, you can answer any question that you choose. And if this comes up in the future as a concern for you, you can talk with me about it. Next, you're going to discuss the pros and cons of use. So you're going to use open-ended questions to clarify, to elicit more information. And it's always best to start by discussing the positives about substance use. This is part of the process that tends to disarm patients. This may be a new way of approaching things that another healthcare or mental health provider has not done in the past. And it provides us as clinicians a better understanding of why clients use substances. The second part of the discussion is to talk about the downside of use. So generally, you want to ask something like, what are the not so good things about use, rather than asking them, what are the bad things about use? Okay. So how might you say this? Another script, help me understand through your eyes. What are the good things about using alcohol? And you may get responses like, well, it relaxes me. I'm more social. It's what everybody does when we go to brunch on Saturday, right? And then you want to follow that up with, well, what are some of the not so good things about using alcohol? Well, I really don't like those hangovers, or I tend to get in arguments more with my partner when I drink too much. And then you want to reflect that back. Again, we're not getting a lot into MI, but I do want to point out you want to reflect this back. So on the one hand, something you like about alcohol is that it relaxes you and that you can be more social. On the other hand, something you don't like about alcohol is that you get a hangover, and that sometimes you get into disagreements with your partner. It's important that the statements that are made regarding the not so good things are what you finish with, right? And that is based on the recency effect, right? You want the last thing for the patient or client to have said to be reasons that might be motivating for change. Always want to use open-ended questions because that helps your client to be able to convey more information. It encourages engagement between the two of you, and it opens the door to further exploration. Another piece that's important as you're gathering all of this information to use are foundational skills, right? Our reflective listening, so that we can, when we're doing summaries and things like that, we can demonstrate to the patient that we are listening, that we understand what their perspective is, because we are essentially using their own words. We're not using our words. So here again, so periodically summarizing what has occurred in a counseling session, that's going to reinforce what's been said. It shows that you've been listening carefully, and it begins to prepare the client to move forward. So this is the decisional balance, which is the discussion of the pros and cons. That's what I just did a few minutes ago. So we can do it again, right? So on the one hand, the pros of use, or some of the reasons why you use, are that you are more social. And on the other hand, some of the cons of use are that you have hangovers. And this provides valuable feedback regarding the potential ambivalence that exists when they're thinking about changing their substance use related behavior. And ambivalence is completely normal. It's a completely normal process when you're talking about health behavior change. So it's okay to highlight that. And when summarizing the pros and cons, you want to think about which negative consequences you want to emphasize. You want to be selective there. You don't want to inadvertently reinforce continued risky use behaviors. And then the next step, providing feedback. So as I said a few minutes ago, it's always best to start by asking permission to provide information. And feedback should include a discussion of the screening findings, a recognition of known consequences linked to use behavior. So for example, if you have a patient or client who is diagnosed with major depressive disorder, you could link that to their alcohol use and mention or ask them rather, did you know that alcohol use above the low risk limits can make your depression worse? In a medical setting, you might say, did you know that your drinking can affect the management of your hypertension or your diabetes? Some of the other ways that you can provide feedback, again, tying it back to what they're experiencing. We know that drinking above certain levels can cause problems, such as maybe it's something that they're experiencing. Maybe it's something like reflux, right? I have some information about low-risk drinking guidelines. Would you mind if I share with you? You can also do some education, right? So for a female, we know that 4 or more drinks in one setting, or more than 7 drinks in a week, or the use of illicit drugs can put the person at risk for illness, injury, and other problems. Okay. And you can say that the same for males. When providing feedback, it's essential to elicit the patient's reaction, process that reaction, be reflective of their emotional response. If they have a negative reaction, it might be necessary to go back to the pros and cons. And affirm that it's your responsibility as a clinician to provide feedback so that they can make informed decisions, right? You want to convey that it is their choice what decision they make about their own health behaviors. And the most important and powerful element of providing feedback is what we were just discussing, which is to make it real for them, right? So we want to use feedback that's personalized. We can also facilitate connections by asking the client what they know. What are your thoughts or feelings about this information? A lot of times when a person begins to be concerned, particularly about their alcohol use, I get a lot of questions about, for example, I have friends and they drink every weekend and I don't drink as much as they do. Why is it that I'm having these problems? I never thought that I had a substance problem because everyone around me drinks a certain way. You want to use reflections, you want to use affirmations, and when you use affirmations, make sure that you're genuine, right? And then summaries, and all of these go to elicit and reinforce the client's own personal insights, right? It helps them to begin to develop discrepancy, to resolve that ambivalence we talked about, and to build motivation. So on the discrepancy, one of the things that you can listen for that you might be able to use in a brief intervention would be someone who says to you, my kids are my priority. I don't work anymore because I want to be there for them. And then they're also sharing with you that they are drinking at excessive levels, right? And so kind of helping them to take a look at that incongruence, take a look at that discrepancy between their values, what they find important, and their behavior. So the third step is building readiness to change. And so this is where we're going to gauge the patient's potential interest in making a change. So the MI readiness ruler is an effective tool for focusing this conversation. If you have a piece of paper, you can draw it out. Sometimes that's helpful. You can also find a lot of this information on various sites. The SAMHSA site has information about all of the successful SBIRT programs that have been implemented across the country. And many of those organizations develop lots of tools to help professionals who are doing this work. So I used to carry a little card in my pocket that had a ruler on it. Also had pictures of the standard drink. That's something I could share with patients. So let's go ahead and start with how you're going to assess readiness to change. First, again, we're going to ask for permission. Could we talk for a few minutes about your interest in making a change? Then on a scale from, if they say yes, on a scale from 1 to 10, where 1 is not being ready at all to make a change, and 10 is being completely ready, how ready are you to make a change in your substance use? You're going to notice that there are going to be very few people who respond with either a 1 or a 10. They're likely to be somewhere in the middle. So, for example, a client might say, I'm a 5. You want to follow that up with some opportunities for change talk. So, and before you do that, you could even provide an affirmation here, right? Oh, a 5. So it sounds like you're 50% of the way there. Right? And then you would want to ask, okay, well, why a 5 and not a 3, right? And that begins to encourage the patient to articulate the reasons and motives for considering a change. So why a 5 and not a 3? Well, because I really don't like those arguments I'm having with my partner so often. And then you could follow that up as well with, well, what would it take, or what would help to move you from a 5 or a 7? And those responses are going to be varied, but again, it begins to help identify some of the motivations and begins to develop that discrepancy that we were talking about. Next is negotiating a plan for change. So this can be one of two things, and it's going to be dependent on the goal that your particular patient has. So is it going to be that they're going to reduce to those lower risk levels? Or is it that the plan, because they are in that top part of the pyramid, is that they will follow up with specialty treatment services? So first and foremost, you want to initiate the discussion focusing on what that client is willing and able to do. So for example, what are some steps that will work for you to stay healthy and safe? Remember that this is your client's plan, not yours. And when creating a plan for reducing use, facilitate concrete steps that the client is willing and able to take. So asking questions like, what specifically will you do to reduce use? And someone might say, well, I'm going to set limits in advance, or I'm going to have a water in between my alcoholic beverages. Okay. How will that help you in reducing the risk? Well, if I go out with my friends and I have this water, hopefully I won't drink as much, and I won't put myself at risk of getting home and getting into the argument with my partner. Okay. All right, how will you measure it? Okay. The easiest quantitative ways, right, are just measure the reduction in the frequency and the quantity. Another way, though, might be that the person plans ahead for having transportation so that they are not going to be drinking and driving. And then the next question is, okay, so does that seem achievable? Okay. And if the answer is yes, by what date do you hope to achieve that plan? Whatever you decide, it's best if the plan is written down and that the client is able to take that with them as their personal plan for change. I have been in the behavioral health field now for 23 years. And so I have a lot of catching up to do when it comes to technology. So up until a couple of years ago, I used to give a lot of papers out. Now folks have really great apps, or they have notes sections in their cell phones. If they're comfortable, these are things that can go there as well. But it's really important that the plan not be complicated, right? And it doesn't need to be perfect. It just needs to be a plan that the patient is willing to follow. And then remember that you want to follow up, right? You don't want to just leave folks out there. You want to follow up and see how they did. And that's an opportunity where maybe you can get some information about barriers or individuals that might be supportive to the person who's trying to make a change. Okay. All right, again, video demonstration we'll come back to at the end. Okay, so we have now talked about screening. We've talked about the brief intervention or the brief negotiated interview. Now we're going to talk about referral to treatment. You're going to see a lot of similarities here because both the BI and the RT are based on motivational interviewing principles, right? So just like if we have a patient who is drinking at excessive levels, who maybe is unaware or hasn't even thought about making a change, someone who may be in the pre-contemplation stage of change, we're not trying to force that person to make a change, right? It's their change, not ours. The same goes for referral to treatment, simply because we would want the patient to go to treatment. It's a lot of this really depends on their readiness. That's why that readiness ruler is so important. Okay. At the end of the day, referral to treatment in SBIRT is actually a really small piece of the pie when you're implementing, and it makes sense, though, right? Because we talked a lot about that middle section of the pyramid, for which BI might be helpful and has shown to have good efficacy. We're not talking about the folks who are abstaining or drinking at low risk levels. For those folks, we're just going to reinforce that they're making healthy decisions. But then we have that top part of the pyramid, right? Those folks that really would benefit from specialized treatment because they are meeting DSM-5 criteria for either moderate substance use disorder or severe substance use disorder. Just an overview of what we're going to talk about. First and foremost, substance use disorder treatment works, and we're going to talk about a few of the strategies that are going to help you to have successful treatment referral. So the learning objectives here for the RT: identify the practical aspects of making a successful treatment referral, identify, and we have a little typo here, identify what substance abuse treatment is. So we don't use that word anymore, and any of you who are in the field of substance use disorder treatment and other behavioral health providers as well, know that we are really trying to destigmatize treatment for both substance use disorders and for mental health. And in mental health, we've actually seen some improvement when it comes to stigma, but we're kind of behind when it comes to substance use disorder treatment. So words matter, and it's important that we use words that are not derogatory, that are not that do not value the dignity and worth of the person. We don't want to say things like, for example, addict or alcoholic, right? We want to talk about the condition. And so a way that we might say, someone who is experiencing a substance use disorder, a person with alcohol use disorder, a person with opioid use disorder, a person with tobacco use disorder. So I just wanted to mention that because stigma continues to be such a big part of the reason why people don't engage with the system, as well as a big part in why folks aren't able to retain patients in treatment. And then practice the use of the BNI for making a treatment referral. So again, we're going back to that same strategy, except this time we are doing it for referral to treatment. So again, this presentation it covers a lot of information. It's translatable to lots of different settings. And this is, although it says primary care, we're really talking about the general population. The evidence suggests that it's only going to be about 5%, right, give or take, of the patients that are screened that are going to require a referral to either brief treatment or specialty treatment. So what is treatment? Right? Treatment at this time, once a person has screened positive, could include several strategies. It could be counseling, it could be other forms of psychosocial rehabilitation. So for example, things like skills training. It could include the use of medications. It could be self-help or mutual aid groups. or involvement with complementary or wellness-oriented activities, things like making changes to diet, exercising, doing yoga, practicing meditation. And a lot of times, and I've noticed this in both the mental health and substance use world, treatment often includes a combination of all of these things. Substance use disorder treatment is provided within levels of care, often available in multiple treatment settings. And level of care is determined by severity of illness. Right? So is this person meeting criteria for moderate or severe substance use disorder? Are there medical or psychiatric comorbidities? And in that case, we want to reserve inpatient treatment for those who have a more serious illness. So it might be a person with severe substance use disorder or a comorbidity. Most of the patients, however, not only can they be treated in an outpatient setting, but they're also more likely to agree to outpatient treatment because it's less disruptive on the rest of their life. Right? Some of you may work in integrated behavioral health or integrated behavioral and primary care settings. In those settings, brief treatment is increasingly being used. Brief treatment is usually 12 sessions or fewer, and usually involving motivational interviewing and or cognitive behavioral therapy. All right, so some guidelines for greatest success. So first, you want to screen to determine the severity of the condition and see if that person needs medical supervision, right? Is that person exhibiting withdrawal symptoms, right? In that case, you're going to need to help connect them with an inpatient setting where they can receive detox services. Those who use substances that maybe are at the excessive level but not meeting criteria for moderate or severe, again, they can usually be treated in the outpatient setting unless there are other risk factors. Okay. All right, so we're back to readiness, right? A strong referral to appropriate treatment is key. So when your client is ready, you want to make a plan, right? And remember that 1 to 10. And I didn't go into the specifics, but usually if a client is reporting 1 to 3, that's indicative of a pre-contemplation stage, which means they may not be ready to make a change. 4 to 6 is they're thinking about it. And then 7 and 8 are folks who might be at the preparation or action stage. They're ready to make a change. It's important that you participate actively in the referral process in settings where you have multidisciplinary teams. The warm handoff is really the way to go. We know that that increases the likelihood that the client will actually follow through. In contrast to, for example, I'm going to give somebody my business card, or I'm just going to hand them a list of local agencies or a list of phone numbers. We know that over and over again, those types of strategies really aren't effective in getting people into specialty care. So you being as involved as you can and having your team as involved as they can be in referral is really the recipe for success. So you also want to think about how you're going to interact and communicate with the referral source. You want to make sure that you have all the correct documentation in place, that you have a follow-up plan with your patient once they complete treatment, and a mechanism by which they can communicate their experience with you, because a lot of times we may not have all of the information regarding a particular referral source. And so our patients can be really a wealth of information in terms of how they experienced a particular organization or agency. I'm going to spend a little bit of time talking about warm handoff, even though there may not be a lot of you in this group who are in settings where warm handoff is customary. But basically, the warm handoff referral is when the clinician directly introduces the patient to the treatment provider at the time of their visit. And the reason for the warm handoff referral is both to establish an initial direct contact between the patient and the clinician, and to confer trust and rapport. The evidence is pretty strong in terms of the effectiveness of the warm handoff, and that the warm handoff referrals are dramatically more successful than those passive referrals that we talked about just a few minutes ago. And the referral to behavioral health should be similar to how a clinician of any type would refer for another service, right? There shouldn't be a difference between whether you're referring a client to specialized mental health or substance use disorder treatment versus if you're in a medical setting, maybe you need to refer to a cardiologist, or if you are a behavioral health provider, maybe you've determined that your client might benefit from a nutrition consult, right? All of these are the same. So I have a few example scripts. So it sounds as if you might be having many challenges right now. I work with someone who specializes in helping with some of these concerns, and I would like for you to speak with them today in order for me to better help you. Is it all right if I introduce you to them? It's one example. Another example is from our discussions today. It appears you are open to getting further assistance to support your efforts. I have a colleague who I work with who can help. Their office is just down the hall. Is it okay with you if we walk there together after we're done here so that you can talk with them for a few minutes? The other option, if you're not in a setting that has a multidisciplinary team, another option would be to ask the client if it's okay if another person in the practice, or if it's okay if you assist them in setting up their first appointment. So once you've determined that they need referral to treatment, what other elements are needed to increase engagement? Okay. And these nuts and bolts are an attempt to really be proactive in addressing common barriers. Okay. So whom do you call? Do you have access to referral resource information? What form do you fill out? What support staff can help? Right. So thinking about, what is your patient thinking when they get home and you've given them information about going to specialty care? They may feel very overwhelmed. They may not want to fill forms out. They may feel like they don't have a direct contact in your practice that they can talk to. So having some of these things ironed out on the front end increase the likelihood that that person's going to follow through with the referral. Some things to consider when you're choosing a treatment provider. And I know that, again, you may not know everything about all the potential referral sources that you have, but it is important to be as knowledgeable as you can be about those local resources, particularly things like, what a provider in a certain community does to address language issues, right? Do they have access to an interpreter, or do they have bilingual staff? What is their approach to cultural competence? Other questions that you might ask, does the agency that you're referring to provide family support? Does the facility have a good record of keeping staff informed of the progress of the client and their ongoing needs? Is the organization accessible by way of public transportation? So again, you're really thinking about what are the barriers, what are the things that stand in the way of a person following through with the referral. Another thing that I like to mention often now is the importance of understanding what the facility's responsiveness is to individuals who have experienced trauma. Right? So we know that there's a very strong relationship between PTSD and substance use disorders. And so our goal is to not re-traumatize. And so we want to have some information about whether, for example, agency X uses a trauma-informed care model. Payment is obviously a huge factor. It is very challenging to get folks in inpatient care because of financial barriers. In cases where a patient does have insurance, does this provider, what sort of insurance does this provider accept? Do they even accept insurance at all? Is this person going to need prior insurance authorization before they can go to treatment? Again, if we don't know all of these things, if the patient doesn't know, then this is a place where they can go, forget it. It's not worth it. It's not worth my time to have to go through this process. And then lastly, if you do have a client who doesn't have insurance and might have a hard time paying for services, is there a provider in the area that offers services on a sliding fee scale? As far as you being the person who's referring folks out, the treatment facilities, assuming that you have all of the documentation in place, right, the release of information, everything, they should be providing you with ongoing updates once that release is signed. If they are not, it may not be a good resource for you. Okay. Another thing that you should expect from the facilities are structured discharge plans, right? Whenever the client is done with treatment, what are the needs for ongoing treatment and recovery? So, for example, does this particular organization or agency have recovery coaches or recovery support specialists that develop a relationship with the patient and can continue to provide support outside? or do they have a relationship with a recovery-oriented system of care that might be able to link that person with recovery support? And then, of course, if they are needing other resources, are those things included in the discharge plan? This kind of goes without saying. The reality is things change a lot. Programs change, their services change. So making sure that you have an up-to-date resource manual is really important. What you definitely don't want to do is give a client a phone number to an organization that no longer exists. Okay, so what are some of the common mistakes that you want to avoid? First and foremost, avoid rushing into action, right? Avoid making that referral when the patient is either not ready or is not interested. Next, you don't want to refer to an agency that is overfilled, right? Maybe this agency has a 3-month wait list, right? That's going to be really challenging. And what's going to happen in those 3 months in terms of your patient's readiness or willingness to receive treatment? Make sure that you are mindful of the payment source. So knowing that a certain agency is not an option because the patient's insurance isn't going to cover it. If that's not known on the front end, that's going to be really frustrating. And then obviously, it's frustrating for patients too when they're asking for help and we aren't familiar with our referral base in our own community. And then it's also important that we consider all of the treatment options. Today, we have wonderful medications to treat substance use disorder, particularly alcohol use disorder and opioid use disorder. They are proven and effective, and they can help tremendously with the recovery process. There is concern sometimes from patients that they are going to be turned away, for example, from mutual aid groups or certain types of recovery housing because they are on medications for substance use, particularly for OUD, opioid use disorder, because that medication that's commonly prescribed is either methadone or buprenorphine, both of which are controlled substances. So there are a lot of myths and stigma again around the use of medications for substance use. But by and large, I think the community is really catching up to how helpful these medications can be, and that we're not talking about substituting, one thing for another. These are medications just like you might take an antihypertensive or other medications if you have some other chronic disease. And then lastly, this is really about us, right? If we are working with a client that maybe we view as resistant or self-sabotaging, we need to really take a step back and remember, just like the other chronic illnesses I just mentioned, these are difficult conditions. They're chronic diseases. They are relapsing diseases at times, but they are also treatable. Some resources here. Nationally, you can look at SAMHSA's treatment facility locator here. It includes all 54 states and territories. And it's useful for you and your staff or other colleagues that you have maybe in your practice to put in the time to see what resources are available in your particular community. So we did that. And here you have some referral specifics for the Houston area. So you have the Council on Recovery, which has treatment matching and intensive outpatient. You have Harris County Youth Services, which is a part of CPS and might be able to provide services to youth who are runaways. They may also be able to access these services through school programs. The Lovett Center, which has a sliding scale fee and intensive outpatient. The Memorial Hermann Prevention and Recovery Campus, which has comprehensive services all the way from detox to aftercare. The Palmer Drug Abuse Program, it's free, it's 12-step based, it's intensive outpatient, and they also provide crisis intervention. And then Teen and Family Services also has a sliding scale fee and intensive outpatient. 12-step referrals, right? You have those here, www.aahouston.org or houstonalanon.org, AA for individuals who are living with a substance use disorder. Alateen and Al-Anon, obviously Alateen is for our youth who are impacted in some way by substance use, and then Al-Anon for loved ones of individuals who have a substance use disorder. These are free. There are lots of meetings in the community. Since the pandemic, there are lots of meetings that can be accessed through Zoom. And what I tell folks, you're going to have folks that come in and say, Al-Anon or AA is not for me. 12-step groups are not for me. And they might be adamant, and that's okay. 12-step doesn't work for everyone. 12-step is also not treatment, right? So we need to make sure that our patients understand that distinction. But you may have a patient that's willing to at least try it. And in those particular cases, what I like to say is, you have to find the right fit. So don't just go to one meeting, maybe try out 2 or 3 meetings and see which one's going to work best for you. Okay, because it really is a wonderful source of support for a lot of people. But just like with anything else, you may need to try on different options for size. All right, so our summary here, treatment works, right? With a minimal amount of preparation, you can know what's available in your community. We provided you with some of those resources. You want to work with your team or with yourself or with the other folks in your practice to clarify what the procedures are for referral. If you don't have the option of doing a warm handoff, that you have some mechanism in place where the patient doesn't feel like they're on an island, right? Because it's really easy to give up when facing the many barriers that can present themselves. And then, of course, you want to make sure that there is a follow-up process in place, right? You want to monitor that. Once again, you're not just saying, here, here's the referral, go to treatment, get better, and I'll see you, next time, right? You really want to make sure that you engage with the patient or client and that they know that you're monitoring things and that you can be an advocate too as they're navigating the world of specialty care. It's a tough journey. Okay, so what I'd like to do now, because I'm happy that we have a little bit of extra time, I do want to show you one of the videos, and then we should have a few minutes left for questions. And I see the chat over there, it's got lots of comments, so hopefully we'll have some good questions there as well. Just 1 second here.
So let me tell you what I normally do
Turn
with
it up.
this interview. You know, we'll talk for up to maybe 20 minutes or so. Normally what I do is just give some feedback from all of those questionnaires that you answered last week. And then we just talk together about that. So, but I always like to just start with wherever you would like to start as well. I am setting the focus, the agenda, but also providing flexibility for Sarah, as I want to see where she wants to begin with the feedback. Had she just asked me to begin by giving her the feedback, I would have done that. But note that when I let her decide where to begin, I reinforce her autonomy and ability to self-reflect. It also allows me to hear her reaction to the questions she answered and hear if there is any concern on her part. I demonstrate that I am partnering with her.
I mean, like when I was doing those questionnaires, it was weird because, I mean, I guess I don't really think about like, you know, like drinking being like this huge deal. And I don't ever really think about like how much I drink. And like filling out like how much I'm drinking every day, it was like, whoa, you know, like I just didn't ever really think about it like that. I was like, if I try to actually count the drinks, it's kind of a lot. I mean, it's kind of a lot.
You were pretty shocked at what you learned about your patterns.
I use a complex reflection to emphasize Sarah's beginning awareness. Complex reflections pick up on the emotional impact for the client. They are deepening of the client's own self-reflection. Change comes when we begin to recognize that our current behavior is discrepant with how we see ourselves.
Well, yeah, because like I also kind of thought that like I drank like about as much as my friends did. And then like I went back and I was like talking to my roommate about it, and I was like telling her that, you know, I was drinking like 10 drinks on the weekends, like including Thursday. So like Thursday, Friday, Saturday, Sunday. And then she was like, Sarah, that's crazy. Like, that is crazy. Why, you know, like, where are you drinking this? And I was like, well, you know, like different places. And I guess like, I don't know, my friends didn't like, no. Anyway, I don't know.
This information has opened your eyes in some ways. And as you talked to your roommate about it, she was even shocked to know that you were drinking as much as you realized when you did the questionnaire.
Yeah. And yeah, I guess it was just like, I thought that everybody was like doing it, you know, but that's not really what's going on.
Yeah, the fact that your drinking stands out from others is clearly not something you had ever really taken into consideration before.
Thus far, I am very careful about using the conversational style of following, focusing on demonstrating my understanding of Sarah's situation and allowing her to continue to talk. The two reflections I have done have picked up on and once again reinforced Sarah's alarm about her drinking. This is beginning to address the importance of her looking at the drinking by just reinforcing what she is already realizing.
Yeah. So that was the thing that like was really the most weird about doing those
Okay.
forums.
One of the things, motivational interviewing did start out in the addictions field and widely used there as well as other fields now. And traditionally, and still very commonly in the addiction field, addiction counselors, many of them have background as addicts themselves. And so there's this whole hardcore approach of breaking through resistance, breaking through denial. People have to be abstinent. This is a very different approach.
It is a different approach. The others have certainly been traditional, and perhaps for some people those have been effective. But in motivational interviewing, we really want the client to be the one who determines if they have a problem. And we want to give them full opportunity to be able to examine this. And then if they decide that this issue, drinking in this case, is a problem, to then help that person decide what their goals are around that. So it could be that Sarah decides over time, as she begins to do in this clip, that she wants to try to moderate. She wants to go to harm reduction.
Mm-hmm.
So we really want the client to establish their own goals. And this is a different approach than has been traditional, often in the addictions field. Yeah. And so when Dr. Miller first began his work in motivational interviewing, it was quite revolutionary for him to approach the client from this direction.
Okay. All right, so let me get this turned off here. Okay. All right, so we do have a few minutes available for questions. I tried to go through the chat here. I'm not sure I saw particular questions, but I may have missed something. Sydney, did you catch anything specific?
Yes, so I'll just go through and read some of the comments and questions if that's okay. So there's some introductions. So I'm just scrolling through. Early on, around 2:11 p.m., Francis Jacobs said, "Universal precautions presumes that everybody is infected, therefore take precautions. Are you saying that we presume everyone has a drinking problem or drug use?"
Oh, that's a really good question. I'm not sure that I would phrase it that way, but kind of, right? We're assuming that there are things that are out in the world that can affect our health, and that there is no way for us to know what those things are unless we ask the questions.
Great, thank you. And Juliet Alecki, excuse me if I'm saying your last name wrong, asked if the PowerPoint will be available for download, and it will be. And I put that in the chat, so hopefully you were able to see that. And so Rebecca Castro asked, a friend has also used, what does it do for you? What does it do to you? So I think that was more of a comment. Around 3:04 p.m., Lovina, hopefully I'm saying that correctly, asked, what makes you a 5 instead of a 6 or 4-4? So I'm not sure if that was a mistake, but do you know what she's saying?
Yeah, so this is around that readiness ruler, right? And there's a strategy, right? So we, if your patient says, well, I'm a 6, which is actually pretty high readiness for change, you're going to ask them, well, why not a 4? You always do the previous number first. And this is all about evoking change talk. So why a 6 and not a 4? And I think I used the example of, well, not a 4 because I'm beginning to see that I have problems with my partner when I drink too much. We get into fights, right? Okay, well, what would it take for you to move from a 6 to an 8? Well, maybe my partner tells me that they don't want to be together anymore, and my partner's important to me, right? So you're kind of getting at that discrepancy as well, in addition to promoting that change talk.
Sure, thank you. And then Lavina also said, oftentimes they would need their meds. I think this was comment on the slide. I've previously supported them by visiting them while they were in treatment to check in how they're managing. And her previous agency, she was paid for ASL interpreter. And then she also said readiness will decrease. Most often they will lose interest until motivated again by a life event. And then she said, I think it's safe to assume everyone has a history of trauma, which may or may not include alcohol/substance use.
So
And
do you mind if I say a few things about
yeah,
these?
of course.
Yeah. So thank you, Lavina. These are wonderful reflections and wonderful information. And you're absolutely right. Readiness can vacillate. This wasn't a presentation on motivational interviewing. However, we do have lots of trainings on motivational interviewing as well. But motivational interviewing is based on the trans-theoretical model of change, or stages of change. And we know that the stages of change aren't linear. So you may have someone one day that is in contemplation stage, right? They're going, oh, maybe this isn't working for me anymore. But then a few weeks later, maybe nothing dramatic has happened and they kind of fall back and go, oh, well, maybe I don't have a problem after all. So I think that's kind of what you were talking about, right? Okay. And then thank you for the statement about assuming that everyone has a history of trauma. So that is the whole basis of trauma-informed care, is that we don't know. And so we are going to assume that everyone has been affected. And so the work that we do, the strategies that we use, the environment that we create should be trauma-informed. Okay? And yes, it may or may not include alcohol or substance use. Oh, this is an interesting question. I have a client saying that the more questions you ask about my drinking, the more craving I feel. What should I respond as a therapist? First of all, that's really helpful information, right? So individuals with alcohol or other substance use disorders have lots of triggers in their external environment. It can be things that they're not even necessarily conscious of, right? It could be that they go past a certain street and it reminds them of when they used to go party there or whatever, or it could be a certain smell. So if this person is saying, the questions that you're asking me are making me crave, then that's something that you can work on. What is it about the questions I'm asking that remind you of drinking, right? And I think the most important thing you can do when you ask that question is to elicit from them what they're understanding. And that's also part of the MI approach, right? It's called evocation versus education. And so we need to understand what they know about something before we can start intervening. And I think that's what I would do. If I were in your situation, I would simply ask questions. What is it about these questions that you feel are contributing to cravings? I think you're going to get a lot of information. You can. So Lavina is asking, can you tell me a little more about that? I would try to get them to evoke more conversation about the trigger. Yeah, absolutely. And your patient or client better than anyone else. And so you're going to know the extent to which you can push and when you might need to fall back. Again, this is MI as well, that you don't want to press too hard because we don't really use the term resistance much anymore in the field because it's got a really negative connotation. We talk more in terms of sustained talk, right? And so sometimes when folks feel like something's going to be taken away from them, they will engage in more sustained talk and sustained behavior, which we previously called resistance. So being aware of those cues, if you're having a conversation with someone and they start looking away, they start to fidget, they start looking upset, that might be an indicator that you have to take a step back. Coping, yeah, absolutely. Absolutely. The best thing you can do is tie what they're doing now to another success that they've had in the past. Hey, do you remember you told me a few sessions ago how when you were 21, you just decided you were going to quit smoking and you did all of these things? Those are the types of skills that can help you cut back on your drinking. Right, so that's where that reflective listening is so important, because you can provide those really genuine and meaningful affirmations. Other questions? Thank you. There's so much content, everyone. I wish we had more time because there is a lot. I think having a little bit more time to spend on the MI piece and getting to practice is always good. But hopefully this training at least is going to point you in the right direction in terms of where you can find screening tools, how you can do the brief intervention, how you can set up a more effective referral process. I don't know. That's a question, I think, for Sydney. Can LCDC also receive the CEU?
Sorry, I was trying to unmute. So for this one, we did not get the prior approval to get it from LCDCs because NBHP is only able to do LMFTs, LPCs, and licensed social workers. But we've made it a priority going forward to at least get our CEU event content approved to include substance use, and also to ask a partnering agency if they can provide LCDCs for us. So unfortunately, this one, I know that it is really unfortunate because this topic is about substance use. And you know what, I could actually ask our partner if we're able to retroactively do that. But I'm not sure because we didn't offer it to everyone. So we didn't offer that as kind of the marketing of the event. So I don't know if it'd be fair afterwards, but definitely going forward, we will. And I'm actually about to put the CEU survey link in the chat. So just as a reminder, 2 hours of credit are available for those select behavioral health providers that I just mentioned. And so you just need to complete this survey by 12 p.m. tomorrow to be eligible. And you must have joined by 2:15 p.m. and stayed on until now. And I also will be sending a thank you email tomorrow with the slides and the link again around 8 in the morning. So if you forget today, you have some time to do that survey. But that's it for me. And there was another question that came up in the chat from, let's see. So Francis Jacobs saying, thank you. It was great, Sydney. Thank you. Having 2 hour sessions was a great idea. Thank you, Francis. You're always here. We really appreciate your attendance. And Mark Mitchell asked, many of the statistics in the beginning used a sex and gender binary. Do the screening tools account for non-binary and gender non-conforming people?
That is a wonderful question. And you're right. And it's largely based on biological sex or sex at birth, because we do know that there are differences in the way that individuals who are born as male or born as female, how alcohol affects them. So to my knowledge, there hasn't been an adaptation of the validated instruments to account for it. So when I'm talking to folks who are non-binary or gender non-conforming, then I'm just going to explain that. We certainly need to do better.
Great. And there was an, oh, sorry. Yeah, Caleb had a question. Caleb Banks said, how does the screening process work for teens or minors as an admission of substance abuse would be cause for a CPS referral, right?
Okay, so in the state of Texas, a youth age 15 and above can get substance use disorder treatment without parental permission. So it depends on what age you're talking about. However, depending on the setting that you're in, you just use your standard, if you're a behavioral health person, even medical person, your standard confidentiality statement, right? Everything that we talk about here, assuming 15 and above, is confidential unless you share with me that you are going to harm yourself or you're going to harm someone else. I just did another training on Friday, and someone said, well, technically, if they're drinking or using drugs, they're harming themselves. That is very true, but we're talking specifically about suicide and homicide.
Okay, that's awesome. I didn't know that about the students being 15 and above. I just work with a diverse population of students, and recently on campus, well, all throughout the year, it's been like an epidemic of vape pens and cartridges, the things that they use to get high or whatever. So providing services has been tough. We had a meeting with the district. I'm a guidance facilitator. I'm not even a guidance counselor, but I facilitate restorative circles and things like that. And when we met with the district, they want us to kind of divulge that stuff to CPS and pass it on. And I had the same thought that you had when we do make that statement about harming yourself or some others. But I was sitting in the train and it just came into my mind, like, how can I incorporate these screenings with my students, and then referring them out for services. Like, I didn't know AA didn't have an AA.
Oh, you're breaking up, Caleb. Oh, we may have lost him, but these are really good issues that are being raised. Obviously, you have to work within the parameters of your organization's policies and procedures, the statutes, the laws in the state. But again, you know, as a professional, you're protected, you know, when it comes to this, because a student can get help on their own. I always tell folks, though, that you know, part of your role working with youth is to, if they're in a safe environment, to work with them on ways that they might be able to be more open with their parents about the struggles that they're going through. And you might be a real source of support for that. I think we're over time, so I want to be respectful.
Okay, sure. Let me double check. So that was all the questions in the chat. If there's any additional questions, I'm free to stay on for a couple minutes. I put the CEU survey link in the chat, but thank you all so much. I really appreciate you coming, and thank you so much, Sandra.
Thank you. Thank you, everybody.